This is the Economic Club of Florida, a distinguished platform for discussion of the major national issues of the day. On today's program, Dr. Dean Watson of Tallahassee Memorial Healthcare System on the unique challenge of COVID-19 and its current Delta variant.
This virus is so aggressive and so good at changing it mutates so well. We've never seen anything like it. This thing is like and I'm not a conspiracy theorist at all, but this thing mutates like a bioweapon. I mean, it is amazing.
Good day and welcome to the 547th in our series of distinguished speaker programs. I'm Harvey Bennett for the Economic Club of Florida. We're pleased to have with us today a visit from the doctor, Dr. Dean Watson, Vice President and Chief Integration Officer for the Tallahassee Memorial Healthcare System. He's been the doctor leading the charge on COVID-19 treatment and prevention in North Florida. Today, the Tallahassee Memorial Healthcare System, based here in Tallahassee, Florida, reopened its dedicated COVID-19 wing due to the surge of recent cases from the Delta variant. As a result, the doctor was not able to sit in for our pre-program interview beforehand. So now, here's Barney Bishop, Club President and President and CEO of Barney Bishop Consulting, with our formal introduction.
Our speaker today is Dr. Dean Watson. He is the Vice President and Chief Integration Officer for Tallahassee Memorial Hospital, and he's the Chief Integration Officer for Capital Health Plan, both the largest providers of health care in the Big Bend of Florida. He is certified in internal medicine, and he's a former Vice President, Chief Medical Officer, also a former Chief Health Operations Officer, and a former Inpatient Director for Family Medicine Residency Program, and the original Education Director for Internal Medicine at the Florida State University College of Medicine. He graduated from that powerhouse Big Ten football school, Indiana University, their College of Medicine. His undergrad, that was a joke.
Yeah.
Okay. Just good. I didn't know if I was going too quick. Okay. You're good now.
We are.
Okay. His undergraduate degree is from the Honors College at Ball State University, where his degree was in biology and pre-medicine with a minor in chemistry. He previously served as chief resident, where he also interned at the Orlando Regional Medical Center, which is a huge medical health provider in Central Florida. His peers have recognized him for his excellence in teaching by awarding him not once, not twice, 5 times as Teacher of the Year. And he's also been awarded the Outstanding Clinical Professor at FSU College of Medicine. In 2013, he was chosen by the Capital Medical Society as the Outstanding Physician Award. I'm beginning to wonder why you're not my doctor. His interests are in teaching. He's been a key partner in creating the Transition Center, which focuses on health care for high-risk populations. It is now my pleasure to introduce Dr. Watson, I presume.
Well, it is an absolute privilege to be amongst folks who, I know a few of you, people asked me today, where are you going to talk? And I said, I have no idea. But I got some phone calls and some powerful people, and I'm going. The PowerPoint I put together, I apologize, y'all. This was rapid. This was a 30-minute production, and I'm open to questions across the board. We'll have, and I hope you guys are interested in learning a little bit about where things stand with regards to COVID. It appears that everybody's been vaccinated in the room, I'm assuming, or else we'll talk after. But with permission, I probably am going to want to move around a little bit. My vision is not great, but I will try my best to work from here so that we can talk about some of the opportunities from the world view all the way down to the local view. I think it's important to understand what's happening across the world, the country, the state, and then local. Then we'll go in to talk just rapidly about the different variants and opportunities related to that, if that's okay with you all. And I thank you for allowing me to do this. I know I was joking earlier, I'm the ambassador from Royal Isle Drive and Golden Eagle, and barely even that, but but we'll try to get some information. And I apologize, the slides are going to be a little bit small. I thought they were going to be on a bigger screen, but this is a world view of activity. And if you look at the world view of activity to just a few days ago, it's kind of a lot of waves, right? Well, we're starting to see an uptick again across the world. Why is that? Well, clearly, not everybody's vaccinated. It's going to be a recurrent theme. But when you look from a world view, that uptick really, believe it or not, is the UK. Okay, it's India, it is the US, it's Brazil, it's Indonesia. Those are the big ones. So those are areas that are being hit with COVID a little bit harder than others, and quite honestly, some of those countries are coming down a little bit. UK is skyrocketing. We're going to talk about that. When you look at deaths, everyone doesn't want to think about this, but this virus is reasonably potent. It is a virus that once you get it, the ability to provide care and to reduce the chances of significant mortality, they're not there. And we'll talk a little bit about that in a second. But when it looks good, right? We went up, we down. We went up, we went down. We went up, we went down. But look at the final portion of that graph. And again, it's not huge, but you're starting to see it flatten, and it's actually starting to rise. So what we look at when it comes to COVID, it's really that 3 to 4 week window after you start to peak. That's when we start to see fatalities. Mortality begins to increase at that time. We're starting to see it again, and that's not what we want to see. We've got to get people vaccinated aggressively. So worldwide deaths are going to start to climb again over the next few weeks. So again, I wanted to use this, and it's not University of Kentucky, that's the UK comparison. We're going to look at United Kingdom just for a second. And I get a little bit of heat because people say, yeah, but the y-axis is different than the US's y-axis, and that's not really what I want to look at. What I want to look at is the slope of activity. So when you look at the slope of activity for the UK, and why pick UK? Because the UK, their vaccination rates mirror ours, but they're a little bit better. That should scare you. They're a little bit better than the US. So the UK came out and they said, we're going to do it differently. We're going to go out and we're going to vaccinate a lot of folks with the first shot, and then we'll worry about the second shot a little bit later. We get it, different styles. The other thing, on total transparency, they're using AstraZeneca as well. They're using Pfizer. They're using Moderna. They're using J&J. They're using 4. The U.S. is really using mostly Pfizer, Moderna, some J&J, mostly Pfizer, Moderna, and that's important. But watch their slope. So their slope is going up, and it's continually going up. They have the most cases per day in the world, UK, right? When you look, we're going to really squint for this one, but when you look at the UK with regards to deaths, well, high, and then another little bump, and then a big bump, and then now. But if you really got close, if you walked up to that screen and looked at it, it's starting to climb again, because they're hitting that 3 to 4 weeks time period after the initiation of their next wave. Okay, that's important. Their vaccination rate mirrors ours, but is a little bit better. So I pulled this out. I can't read that, but I'm going to walk up a little bit closer. I'll be right back for the camera. When you look at, when you look at their rates, first dose rates for the UK, really, really good, 7%. 7% first dose. Second dose completion, in other words, they complete the vaccination 14 days post, is about 54%. Okay? So 70%, 54% UK. We're going to walk into the US. The US, again, mirrors what the UK was doing. It's kind of up and down, up and down. Boy, did we have a heck of a time a few months ago or back in December. Then you move into current day. Where are we headed? Right behind the UK. We're starting to climb again. Exactly what we don't want. When you look at our deaths, no, we're not really skyrocketing or anything, but what's happening? Beautiful trend down, and then what happened? Now you see the slope is stopped. It is flattened out. Not exactly what we want to see. And I promise you all, I'm not an alarmist. I'm just a realist. And just to make sure everybody understands, so since the beginning of this, I've been embedded in and helped create the COVID team, have been helping manage the activities locally. We are, and I'm just want everybody to recognize, I know when I look at all this stuff, my blood pressure goes up a little higher than others because the majority of my life is buried in a hospital watching people deteriorate and die. Okay? And so take that, and I tell my wife the same thing when I come home, honey, the world's ending. No, and she's like, well, it looks pretty good to me. Well, I know it does here. But I just want to be, so don't think that I'm going to tell you the world's coming to an end. I just want everyone to recognize the importance of what we're doing and how we can impact this and stop it. This is what we want to do. So it's flattening out. When you look at hospitalizations for the U.S., that's worrisome because we went up, down, and then boom, and then down, and then boom again, and then look where we're headed again. Okay, hospitalizations. And let me tell you this. Those hospitalizations in those last two humps were 60, 70, 80-year-olds. Where do you think the hospitalizations are right now? They're not above 65. You know why? Best group in the country. The 65-year-olds and above came out and said, enough of the politics, we're going for it. And you did the right thing. 65 and below, they're not doing it. And I'll show you another slide here in a second. But 20 to, right now, and I'll talk local if you don't mind, right now it's 20 to 60-year-olds filling up the hospital. 30 of them in this morning when we walked in. Okay? So the hospitalizations are starting to climb again. And again, I know, so I'm so sorry, guys.
Dean, a quick question while you're walking up there. These are unvaccinated?
Repeat the question, Doc.
Yes. Yeah. So Steve asked the question about vaccination versus unvaccinated. Of the 30 patients that we had this morning, 29 were vaccinated. I don't know if there's a correlation. I'm still So we went back to UK, using this example. Obviously, the U.S. populated, is populated. Well, the accountants, because I get that from other accountants. I got it so low in terms. But 57% first dose in the U.S., 49% fully vaccinated, and 2 shots, 14 days post. So we're trailing behind the UK, which is 70%. We're at 57% for 1 dose at least. We're going to be in for a show here just a little bit. Again, not a fatalist or a overreactor, but I just want some reality here. Let's move to the state of Florida real quick. Lots of good things going on in the state of Florida. Activities, people are coming back. Great. We're doing well financially. That is all fantastic news. The issue being now the state of Florida is one of the leaders or actually the leader in new cases. So, you know what? Again, not overreacting. The majority of these cases are young folks below 24, right? Well, it makes sense because the kids are back out in camps. The kids are active. I get it. But those kids also can infect older people or middle-aged people and impact our outcomes. So we'll talk a little bit more about that. So just be aware that the state of Florida, we're climbing back. If you look at our third peak, this is really our fourth peak, but on this graph it doesn't. If you look at the peak just to the left, we're beating those numbers already. The good news is the daily deaths in the state of Florida, again, are flattened, and they're still decreasing just a little bit. Rule of thumb, again, for everybody is 3 to 4 weeks. After the peak is when we start to see the fatalities start to roll in. It's a delay because it takes a while for the virus to replicate and then do its job of survival and then take out the host. And that's how it works. So we're flattening out with regards to the deaths, but I would not be shocked to see that to start to climb in the next 2 weeks. Just as and again, I'm so sorry, y'all, but when you look at this, this is the COVID vaccination by age group. This is a little old, and I will tell you, hopefully this won't interact, I will tell you the problem with the data collection today, and I don't mean this in a derogatory fashion, but is that the state of Florida decided that we weren't going to report like every other state. Well, that impacted us because we had the ability on a daily basis to go in and pull the data and affect it. So we would be looking, and me in particular, would be looking at all of the vaccinations, all of the infections, and know where they were. And we created our system using that data. Well, we don't have that data anymore. So a lot of the data we have is 1 week old, 2 week old, so that has impacted us. But when you look at this test real quick, you can see that I highlighted these to the best of my ability. This is from a month ago, and this is the vaccinations by age group. And you always say, well, this is not rocket science. It isn't. 65 and over, 77% in Leon County completed their vaccinations. Move on down the line. 55 and above, 61, 45 and above, 50, or 45, 54, sorry. 35, 44, 41. Get on down here, and I just told you the highest number of infections, or the highest number of infections by age group recently is below the age 24. Well, it makes sense because they're not vaccinated. And it's not, not rocket science, but it is an awareness opportunity for college kids and others. One thing that I did want to show you is that from an eligible standpoint, across the board in Leon County, 41% back here in June had been vaccinated. 41% of the eligible. Well, the overall vaccination rate for the population of Leon County was 36. It's up to 43% as of a couple of days ago. That's a good sign. People are coming out and starting to get vaccinated. Increased by 7% over the last month. Good sign. All right, so moving on here rapidly. I know you guys are probably, love it. There's no way in the world. So this is relates to, and I just want to give credit to an FSU professor who's amazing, and many of you know him or may not know him. If you don't, you probably want to get to know him. He's a rock star. Is Jonathan Dennis. He's a professor in biology. And let me tell you what happened. This is a great feel-good story, is that we, during this pandemic, so all of you all are aware, we could not get tests done. You come into the hospital during the early COVID, and we have you hospitalized for 7 days, 8 days, 9 days, 10 days, waiting for a test. We assume you have COVID. You're in a hospital bed sick, and we're waiting for a test result to come back. It was horrible, y'all. You couldn't practice. It was a third world intervention locally. I mean, everywhere in the U.S., quite honestly. We partnered, meaning TMH partnered with FSU and Dr. Dennis, who came up with a way to identify and test for COVID. This changed the war for us because we would swab, sent the battle improved, I should say. We went over, sent the studies over to him. TMH FSU created a local lab for the whole region. We could get our test results back in less than 24 hours. World of difference. It was a game changer. What I list here for you is, and just kudos to him, and he's just the greatest guy, so you just want to say everything positive. Alpha, Gamma, Delta. Why does it matter? Alpha variant was the first variant, and I just remind you all, it's kind of like sports. They start out, and I should have Steve Evans give this talk. He's the baseball player. Start out in college, then they go into the minors, and then they go into the majors, and that's what you're seeing happen here. These Alpha came out and said, yeah, I'm the big dog, I'm COVID. Well, Alpha said, I'm going to go out and start infecting people. It was highly transmissible. It was taking out folks, but it had no idea what was to come. Followed up by Gamma and Delta. Gamma got a little bit stronger and a little bit more resistant to our therapies, including monoclonal antibodies, which you all hear about on the news. I need to go get my monoclonal antibodies, my infusion to save my life. Well, small percentage chance that it's going to impact you at all. Well, these viruses said, well, I'm watching the news just like you're watching the news, and I'm going to change my structure so nothing you give me is going to improve anything. And that's what you see happening. Remember, I say this all the time, viruses have one job, and that is to survive. They don't care what they do to you, and that's what they're doing. So they're all mutating. This is not just 3 mutations. Hundreds of mutations. These are the mutations that come out and take care of business. These are the ones that said, you know what, all you other mutations, you're the minors, we're the majors. And Delta now is the leader of the majors. Delta came out and it's increased its transmissibility. You all know this came out of India and increased its ability to be transmitted from individual to individual. It said, you know what, I know you guys are using all this plasma antibody stuff, but you know what, for me, you better come at me a little bit harder than that. What about those monoclonal antibodies we hear about? Yeah, the ones that you guys have been using, the BAM, the ETE, doesn't work on me because I'm the majors, and that's Delta. We do have one antibody infusion that does work for Delta, but soon enough there will be the next, and we'll be having this talk, and I'm going to tell you, Delta just got replaced. So this is, and I know not to bore you all, and I was on a radio, I don't know how these things happen, I swear, but I was on the radio this morning, and who knows, but anyway, I hope I said good things. But what they asked was, Delta, and I said, stop. It's not about Delta. It's about vaccination. Because until we vaccinate, until we get people to vaccinate, these conversations are never going to stop. They're just not. For everyone that says, well, we're going to go, no. You see those waves? It's going to be wave after wave after wave after wave after wave until people get out and get vaccinated. Well, what about everyone, herd immunity? Well, okay, we can go that way, but with regards to herd immunity, what's the guarantee that your antibodies, your natural humoral antibodies, are actually going to be effective against the next variant? There is no guarantee. So I left this for you all because, and you all can get the slide deck and look at all this stuff, but this comes out of Dr. Dennis's lab. And up until the last few weeks, we had not seen Delta. Okay? So all these folks that were getting sick, no, they were alpha. They were just the alpha. They were the early majors. They got to bat if their team was up. But the Delta, we knew it was here. We just hadn't picked it up yet. And Dr. Dennis's lab picked up 65% Delta like that. What does that tell you? It tells you the whatever color line, maybe that's orange, red, I don't know. But probably some gators in here. It's probably orange and blue. But the line is skyrocketing exponentially. That's where we are. And we knew it. There's no surprise. No one should be scared and say, oh my gosh, Delta. No, we knew it. We knew it would be here. And it's replicating like crazy. What's the answer? Vaccination. This is just more information for you all to read through. I did want to take just 2 seconds, if I may. And I'm very passionate about this COVID stuff. Obviously, it's been really a big part of our lives. Testing. There are 3 types of tests. And I don't want you all to be fooled. And I'm sorry if someone owns a business in here that does antigen testing. I promise you I don't dislike you. I probably would like you very much. But antigen testing, the one in the middle, is not the gold standard. So when everybody's driving up to this and driving up to that, and I'm going over here and I got swabbed and I was negative, and I say, well, did they do it right there and did they tell you your answer right there? Yeah. I said, well, that was an antigen test. So you need a PCR if you're symptomatic. So I just want to be really clear. Antigen tests are really reasonable if you're symptomatic. They're going to pick it up. If you've got a high viral load, they're going to pick it up most of the time. Not all the time. Why is that important? Because you're seeing it happen right now. People go and they get an antigen test and it comes back negative and they're like, that's crazy because I don't feel good. What are they doing? They likely have it. They're back at work and they're spreading it. This has been my argument for, I don't know how many years, a year and a half since this started. Be careful with the antigen testing. I'm okay with it. I use it appropriately. If you're symptomatic and I test you with an antigen test and it is negative, what am I doing? I'm getting a PCR immediately. The PCR on the left is the gold standard. We have, and that's Dr. Dennis's lab. He does PCR, TMH does PCR, CRMC sends their PCR out of town, but they do it. So the gold standard is PCR. Antibody testing, I'd also caution you on that. One big thing here, if you've been vaccinated and you say, you know what guys, I want to be tested, I want to prove that my vaccine worked. Up until recently, if you got antibody tested for vaccination effectiveness, didn't tell you anything because the antibodies they were measuring were not the antibodies directed at the spike protein, which is what, it's too technical, I know, but it wasn't measuring the right antibodies. Now the commercial labs have shifted over. So if you have been vaccinated and you want to see if your antibodies are there, you can do it now. But prior, I'm going to warn you. If you went and you said, well, that vaccine didn't work. Not true. The antibody test was not appropriate. So does that make sense? I don't want to bore everybody with that. And the antibody tests that you do, the finger sticks and all that, they're not that good. So if they came back negative or positive, I'll be like, you may want to actually send it to TMH or LabCorp, Quest, or one of those others. But I'm passionate about this because we have a lot of folks out there that wanted to generate a lot of revenue off of the backs of this illness, and all you're doing is impacting us because these people are actually infected and they're coming back to the hospital, and that's not good. Rapidly, I promise you I'm not going to bore you with all this stuff, but these are all of the treatments, quote-unquote treatments we have right now, convalescent plasma, meaning taking an infected person's blood, taking their antibodies out of their plasma and giving them to somebody else. Does it work? Yeah. I mean, works better than nothing, but there's not great outcomes with it. Remdesivir, you saw recently that the most recent study showed remdesivir really wasn't beneficial. We have conflicting studies now, but again, we have very few things that we can do. So this antiviral comes in, and if you're really, 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 really sick, we're going to try it because we've got to do something. As doctors, we don't want to stand there and just watch you deteriorate without anything. Again, I just said that, but WHO came out and said, we don't think it works. So monoclonal antibodies we talked about. We're down to one set, which is called Regen-Cov. It's a combination of two monoclonal antibodies. It's one that I believe Trump was touting a long time ago. That's the only one that works right now. And again, remember, as they move out of the majors into the World Series, we're going to be looking for different opportunities. Statins work, so if you're on a statin, good for you. It's anti-inflammatory. It also impacts one of the receptors in your body that reduces the impact of this virus. Zinc, it works. Many of you probably take Cold Ease when you get a cold. That's what it is. Melatonin, if you can't sleep at night and you're taking melatonin, good for you. It reduces the bad outcomes related to COVID. Anticoagulation is key. You talk about craziness. Patients with COVID that come in, they're either bleeding or they're clotting. And you're, okay, well, what is it? Well, it's one or the other. So it's a battle to figure out, do I thin their blood or do I not thin their blood? Do I thin their... It's a never-ending battle. But anticoagulation in the right population does improve outcomes. The biggest one, believe it or not, so this was the battle of all battles. This was like the WWE, or whatever it is called now. World Wrestling Federation, whatever. But dexamethasone, when it first came out, people said, no way in the world will you give steroids to this population. What are you talking about? You're going to drive their immune system into a point where it's not going to be beneficial. They're not going to be able to fight the virus. Well, as it turns out, dexamethasone in a population that has low oxygen concentrations, the inability to breathe, actually is beneficial. So this is welcome to medicine. You do it, you don't do it. You do it, you don't do it. But evidence-based is the most important part. We don't do anything without evidence. So there are a lot of people out there that are doing certain things with, you guys have ivermectin and other things, and I just caution you. Vitamins. Here's the beauty. Vitamin C, vitamin D, excellent, right? Those are the big ones. I can tell you a personal story, which is not good. So I broke the record for the most surgeries in the shortest period of time 2 months ago. And I truly believe, because I was on the COVID wards and all that kind of stuff, and I was on high-dose vitamin C and high-dose vitamin D, and I wasn't drinking enough, and the rest was history. But I obstructed my kidney and stones and then ruptured a ureter, and I said, all right, reduce the vitamin C and vitamin D. So be careful with how much you take. But it is beneficial in prevention. So if you can replace, 500 a day of vitamin C and the vitamin D if you're on supplements, that's great. As long as your vitamin D levels are normal, you're good to go. And last but not least, one more slide before last but not least, the types of vaccines out there. I've listed these, and you all can look at them, but the best ones currently are the mRNA vaccines, and we can talk about that a little bit if you like. I will like to dispel some of the rumors that, we were just talking about this morning, that some of the kids think that you turn into a magnet or something, which would be really cool, but it doesn't, and it doesn't have little things that follow you, that know where you are on the earth and have tracers in it, and who knows, cameras and things like that. I have no idea. But it doesn't do all that, because when you take an mRNA vaccine, which is nothing more than a delivery system, right? So it took them forever to figure out, how do I take this delivery system, get it in the body without the body destroying it, right? So they figured it out, wrap it in lipid or fats, wrap it in lipids, wrap it in other things, and they finally figured out how to get it into a muscle cell. Well, when it arrives in the muscle cell, that messenger, I make it as simple as that. They arrive with the message and they say, hey, y'all, you need to produce this one little piece of protein. Okay, you got it? Yep, we're gonna produce it. Awesome. And then they're destroyed. It's destroyed. The body then produces that little tiny protein, keeps producing it, and the antibodies then come along and they're like, hey, that's not normal. What is that protein doing here? And they start to produce antibodies against that protein. It's as simple as that. So the mRNA vaccine it doesn't go into your nucleus. Why is that important? Because everybody says someday I'm going to have 5 ears and 6 arms and a tail. No, well maybe, but that doesn't go into the nucleus. And that's where all your DNA is stored. So all of your information for your genetic makeup, for your for cancer production, all that, it's in that nucleus. It never enters that. So I'd like to dispel that at this moment. Now, last thing I'd like to say, and I thank you for allowing me to bore you all to death, but she's very proud of what happens in this community. A couple of things. One, within 2 days of recognizing this thing was going to be a disaster, we pulled together, and that includes this university, we pulled together a group of people within 2 days and had a drive-through testing site up within 2 days. Okay? And I say 2 days. What I mean by that is we had the design up, we started to go get the cabling and all that kind of stuff, but 2 days it was set in design, ready to go. And that took care of the community. That was TMH, that was the other hospital in town, can't say that name. That was Bond, that was Neighborhood, it was FSU. I mean, obviously Department of Health, who did a good job, should be proud of that kind of stuff. In my 26 years in Tallahassee, even though this has been a horrible experience, not as bad as the kidney stones, but this has been a horrible experience, I was so proud of this community. I'm so proud of what happened, and includes Capital Health Plan, by the way, who was, they were on the forefront of that. So, COVID team. Let me tell you all what happens locally. We activated the COVID team last week. TMH has a COVID team. It's a COVID team that, and I will never use I. We created this team. And in that team, we took a group of hospitalists, a couple of pulmonologists, radiologists, a great group of nurses, awesome group of nurses, and developed a team that said, this is all we're going to do. And remember, when this started, everyone thought they were going to die from it. So think about how brave these people are. We came to them and we said, all right, here's the deal. And we were the Ebola team. Okay, love Ebola. But we were that team. So you come in, and these guys and gals are brave. They did it. They stepped up to the plate, respiratory therapists. Why would we do that? Because you want to standardize your approach. We didn't want to have 50 people doing this and having a different approach. We also wanted to protect the rest of the hospital. So we had this group come in, and I'm a part of the group, is say, we're going to do this. 0 infections occurred in that group. Okay? Why? Because that's all they did. That's all they did. I'm very proud of them. And now we've reactivated them, and I'm going to be honest, like they asked on this radio show this morning, is, well, how are the healthcare providers doing? They're tired, they're frustrated, and they're sad. Because right now they're taking care of 29 out of 30, and it's changed because I've been away from the hospital for an hour, so maybe it's whatever. But when they see a patient, and they tell me this, when I go in to talk to the patient and I say, why didn't you take the vaccine? Why didn't you get it? I mean, because you have a chance to die. And right now it hurts them because they watch these 20-year-olds, these 30-year-olds, these 40-year-olds, these 50-year-olds die from something that was preventable. And as a doctor, that's your worst nightmare. Because otherwise, if it's cancer or something, you're like, yeah, I get it. And unfortunately, we all have issues. But this is one that we can prevent. And I'll end it on that. Okay, so
Okay, questions? Please come up to the microphone.
I got to give her the microphone. I'm sorry, I stole that. All right.
Oh, she's got a microphone right there. Yes, sir.
Is it working?
Yes.
Could you please comment on how, and you may not know,
Yep.
how long does antibodies last, and whether or not we're going to need a booster shot? And please comment on whether or not people who've been infected and have recovered, whether or not they should be vaccinated.
No questions? Yeah, those are great questions because let's start backwards and then you have to repeat because I get carried away in these things and I have to repeat your questions. But people that have been infected in the past have what's called humoral immunity, right? So it's natural immunity, same thing. And the issue there is a couple. One is that the likelihood or the possibility that they will maintain a level of antibody production directed at a new variant is not good. That's what scares us. And you can say, yeah, Dean, but how scared are you? Well, I will tell you right now, if you said, Dean, I've had the infection and I'm scared to get vaccinated, well, let's talk about it. We have some time. You know, how long ago were you infected? And I don't want to go into too deep because you guys will fall asleep. There's also B cell and T cell immunity, which we can talk about if you're interested, but it's a memory of your body. Your body has a memory of antigens you've been exposed to, and we're still researching the ability for your body to react to all of these COVID variants. Here's the problem, folks. This virus is so aggressive and so good at changing it mutates so well. We've never seen anything like it. So if you're talking about, well, I had X virus in the past and I'm immune to it and I got vaccinated for polio and I'm doing great. Yeah, because it didn't mutate like this. This thing is like and I'm not a conspiracy theorist at all, but this thing mutates like a bioweapon. I mean, it is amazing. It's incredible how this thing can change its design. So I would argue that for folks that have had the infection, your risk is not booming. But I will tell you this, you're not as good, you're not as safe than as if you got the vaccine, because the vaccines are designed to battle this mutating virus. That's what their design is. When you look at the mRNA vaccines, the cool thing about mRNA vaccines is that they have the ability to change the design, the target rapidly. They can go in and go, oh, right, we're going to change the target to spike protein 102 rather than 103. Do it. Release. And they give you another shot, which relates to your booster question. Remember that immunity is determined by the level of antibody production in your body. And what we know right now is that, and I'm going to talk about Moderna and Pfizer, if you don't mind, and we can talk about J&J if you like, but Moderna, Pfizer, right now what we know is that the immunity for Moderna and Pfizer is still good, even against the Delta. When you look at the outcomes data, and they're doing it all the time, this is going to change every minute, it's still good, 88% even against Delta, which is incredible, right? So people use a term that I really don't like, and it's breakthrough infections. Okay, well, all right. So if I tell you you're flipping a coin, and you've got a 50% chance of a tail and a 50% chance of a head, and you flipped it, and you got it. Well, I want a tail, and you get a head. Oh, dang it, it's a breakthrough head. A breakthrough head was expected. You got a 50-50 chance, right? And this is all media political baloney. It's not breakthrough, it's expected. So if I get infections that are hitting 20, 30, 40, 50, 60%, then we're breaking through. Because we know that the immunity using these vaccines should, especially now with the Delta, we should be really 12% maybe expected, 14% maybe expected, right? And as it mutates, I'm going to be looking at you going, 20% expected, because people still aren't getting vaccinated and they're letting this thing mutate. Okay, boosters. Boosters are beneficial if you can, if we start to see that the antibody production starts to drop, wane over the next 3 to 6 months. Yeah, we may have to boost it. And quite honestly, if they're going to boost it, they probably give you the same shot, or they may redesign. They're already working on the restructured vaccines for the Delta Plus. I say the Delta Plus because there's more than Delta. Right now, boosters are not required. Honestly, if I had to beg, I'd say, you know what, boosters are something we need to think about, but please, how about just getting a vaccine? I mean, that's where we are today. But boosters, I won't be shocked, kind of like the flu boosters in the next year. I won't be shocked at that. And the reason, again, is because not enough people are getting vaccinated. These mutations continue to occur. Look at your neighbors, if not here, because you guys are all vaccinated, but when you go home, just say, hey, how are you doing? You got any milk? You've been vaccinated? Just kidding. Did I miss one? I'm sorry, because was that it?
Yes.
Okay,
Yes.
thank you.
Other questions?
What's the current standards for children?
Yeah.
Yes.
I'll tell you. So actually, I got my, hey. I tell you, I don't know how I got my medical license, I swear. All right, so What are the standards for children? So right now, 12 and above. And the studies are ongoing looking at pediatrics. It's a really interesting conversation because, and look at UK. UK decided that really pediatric-wise, we're going to leave that alone. We've got a big issue with people dying as adults in UK. America or US has had an issue there as well. But from a pediatric standpoint, we're not seeing as much mortality, bad outcomes. You'll see it on the news because it's newsworthy, right? 1 person in a billion, they have this thing. Wow. You're like, I'm not going to win the lottery with that. But here's the concern that I would raise as we're thinking through this. As it mutates, we just showed you that it learns. So it's like, hey, 65 and over have been vaccinated. Yeah, they're good. Let's drop down to the 20 to 60-year-olds that aren't vaccinated. I want to survive. And that's what it does. So when you start to see the 20 to 60-year-olds either die or have humoral immunity, natural immunity, then it's going to continue on. And it's trying to do it now. Look at the pediatric infection rates. Obviously, I almost said Indiana. Oh my gosh. Whew. Grew up in Indiana. But in Florida, you look at the infection rates. They're high. It's hard to follow them because, again, we're not reporting every day. It's happening. I think the biggest fear everyone should have, and we argue this stuff over. I had a call from one of the smartest guys I know prior to walking in here, and said, I want to talk about this vaccine thing. And he's walking through it, and I'm like, I said, you got to accept. Just accept. It is that what his argument was, well, when I'm vaccinated, what happens in the long term? What about 10 years from now? When I have cancer from my mRNA vaccine, I said, look, I explained to him the whole thing. What happens to our kids that have been infected, right? Because it impacts the heart, it impacts the kidneys, it impacts the lungs, it impacts the brain. So 10 years from now, these poor kids, who knows? And you can argue this. Well, who knows about vaccine? Yeah, well, I know that I don't want to die yet. All right, so if I get infected, who knows what that's going to do to my kids? I have 4 kids. One I'm battling with, to be honest with you. She told me all of my family's vaccinated except for one child who just turned 16. And she told me it's my right. And I said, yeah, it's your right to tell me what day you want to be vaccinated. And because she turned 16, I said, when you turn 16, this is just had happened when the change dropped to 12. But anyway, so it's a battle, and I understand it, but I'm passionate about trying to do what's right.
Christopher.
You can probably hear me. 2 questions. One, how effective was the mask? Was it really a benefit or not?
Yeah.
And there's a tremendous dichotomy right now where the federal government has said no mask and certain states have said no mask. You go on an airplane and everybody starts fighting. What give? Second thing is a discussion about the long-term impact on the human brain from it, and where does that stand?
Yeah, so masking. I'm always transparent, unfortunately. Yeah, I didn't buy into the mask theory initially, and I'll tell you why. And then I'll tell you where I am now. Is that the size of the particles of the coronavirus and these masks, and I have, where I am now, is the size of the particles were so small that they weren't going to be filtered in a mask. It just wasn't going to happen. And then you saw a shift to surgical masks and what other masks that we use in the hospital. They do work. Especially in the healthcare industry, they do work. Let me tell you that one of the things in public, I will tell you, why is it beneficial to mask? A couple reasons. One is it reminds you not to touch your nose or your mouth. Isn't that crazy? But it's true. So when you're in public and you've got a mask on and you're not, I'm not saying you're picking your nose, I'm just saying that you're not rubbing your nose, you're touching something, opening a door, and then you put it in your mouth. And that's how you get infected. And it also is beneficial. What they've found, there are studies now, because now we're getting far enough into it to actually see real studies, right? They are finding a reduction in transmission in individuals that wear a 3-ply mask. So I support masking. I'm not like this rigid, crazy guy, that says everybody outside when you're jogging, wear a mask and run down I can't even breathe when I'm wearing a mask, so me running would be the end of me. But so I do support masking, appropriate masking. The hospital supports appropriate masking. I think it's beneficial for more than one reason. I think masking, remember, as an education point, I used to be a teacher a long time ago. Masking is beneficial for you to prevent spreading to the other person, not the reverse. So if you have a mask on and you're walking down in Target and you're like, yeah, you can sneeze all you want. No, it's not true. It's when they sneeze in their mask, they're preventing that large droplet mist coming out of their mask. That's the prevention tool. I know it's crazy, right? So if you're sick, you should be wearing a mask. Now, when you double mask, meaning you wear a mask, I wear a mask, there is an increase, and I apologize, y'all. And someone called me like at midnight last night for this, but just to use them burn. But I do have a graph that shows the benefit of masking, a reduction of transmission. When it relates to cognitive issues with regards to COVID, who knows yet? That's the problem. All the studies you're talking about, lung, heart, kidneys, brain, are ongoing right now. Long COVID syndrome, what about that? People are getting infected, and I've got friends that they feel miserable months after they had COVID. It's called long COVID syndrome, but there's so many things that we don't know.
Mm-hmm. Yes, ma'am.
In 3 weeks, we go back to school, and this town changes with a lot of young people.
Yep.
What do you advise? What can you tell us?
Yeah, that's watch the numbers go up. Yeah, I may want to run for office someday, and I don't want to say things. I personally believe that if the kids are coming back to school, and even push this a bit, 18 and over kids should be getting vaccinated. And I call them kids because I've got 3 of my 4 are 18 and over. And they should be vaccinated coming back to college. It's not fair for these kids to be putting the college professors at risk. And I get it. Choice is everything. I support free choice. I do. But I'm a bigger supporter of personal responsibility. And I think that these kids need to be vaccinated. And I know the state of Florida does not want to mandate it. I get it. I think it's wrong. And I'm sorry, I'm not running for office right now.
Yeah. What about young children that are going to school, like first through 8th grade? Should they be mandated to wear masks? Should they wear masks?
I think I will tell you, as of right now, it's going to be interesting to see what happens. I think it's miserable to wear a mask all day long. I think until we're assured that this thing is decreasing, I think they're going to have to wear masks. It's unfortunate. And again, guys, it's not the kids. They're going to do great. For now, you don't know 20 years from now. It's who they're bringing it home to. We have more cases in the hospital where, my kid got back from Camp COVID, and I got pneumonia. Yeah. Well, I don't know what to tell you.
Jim?
So I appreciate, because I have a lot of ER doc clients, and I get a lot of information from them.
Yep.
My very personal opinion is that what I saw my children go through last year at Holy Comforter, who did a great job to keep them in school, is not going to happen again. I am not allowing my children to be raised with masks on. That's just me. If I get sick, that's my fault.
But it's not just you.
I'm just saying, my wife and I are not going to let our children grow up this way.
But you've been vaccinated, correct?
No, I can't, because nobody can tell me the effect on my heart, because I had myocarditis about 8 to 10 years ago, and I've asked a very good primary care. I've asked like 6 different doctors, and nobody can tell me. My wife's decision is hers, not mine.
Yeah. You and I will agree to disagree, because I respect
children
it.
or the...
No, both.
Okay.
Yeah, and I'm a real good old doctor too.
Well, I'd like to talk to you then, because my doc can't tell me.
Maybe just old, not about the real good. But
well, my doc's kind of young, I guess, the guy I got, but he can't give me an answer on what that vaccine is.
I don't expect him to be able to, because he's not buried in it. Let me just remind you all, your primary care doctors have not been buried in COVID. They pushed it all to us. When this hit, all of the COVID, they shut their doors on COVID. They wouldn't let them in the building. That was us. So I appreciate their thoughts on it, but I'd like to talk to him. I probably trained him, by the way, so I trained him. I'm going to have to spank him. That's true.
I'm going to ask the last question, Dr. Watson, and that is, you had mentioned earlier that there's going to be other variants of this. So it appears to be, to all of us, that this is a very unique virus. Do you want to comment about, do you think this is man-made or whether it came from nature? As far as, only to the extent to educate us.
Nice seeing everybody.
I can't tell you.
The man's listening.
That's right. going to tell you what political persuasion I am either. I don't. It's a unique virus. It'll be interesting to see the outcomes. We know, I'm pretty sure that it's going to be a unique, manipulated in some way or another. I don't think this is natural. Do I think it's intentional? No. Do I think that, we have all kinds of interesting opportunities and actions going on in labs trying to create cures for things, and who knows what happened. I don't think it was designed to come out and hurt people. I think that it was just something that got loose, and it was a delay in communication, which was horrible, which impacted the world. Okay. Is that politically correct?
You've been listening to Dr. Dean Watson, Vice President and Chief Integration Officer of the Tallahassee Memorial Healthcare System, speaking before the Economic Club of Florida on July 22nd, 2021. For more information on the Tallahassee Memorial Healthcare System, visit tmh.org. The Economic Club of Florida promotes interest and enlightenment on important economic, political, and social issues of the day. To learn more, including how to become a member, visit our website at economic-club.com. This program was recorded at the Florida State University Alumni Center in Tallahassee, Florida.